Thank you very much for the introduction. I must thank my very dear friend, Dr. Jayakrishnan. I think I'm one of the common factor here in this conference. This is the 13th conference. I have come for the last 12 years. For the 12 times I have come for this conference. So it's a great pleasure once again to come. And I think Jayakrishnan beautifully explained about anovulatory infertility, and Professor Roy Hamburg very well explained to us about the role of clomiphene citrate and low dose FSH. But I have been given this task to talk just yesterday, 2 days back, by Dr. Jayakrishnan, because Dr. Salim Daya could not come to India. So I have made my slides over the last 24 hours, collecting some information as much as possible. But I understand it is not easy to talk about metformin now, because we thought long back metformin was the choice in polycystic ovarian syndrome, and everybody gave metformin. And I understand people still give. But today my job is to make you understand not to give metformin in at least a good number of patients. I bring greetings to you from the university town of Manipal, from Karnataka state. That's a university building with 4 floors of library for students. We very well know that increased insulin resistance, hyperandrogenism, and obesity pose a significant impact on reproductive health. It is logical to assume that therapy that achieves a fall in serum insulin concentrations should improve the symptoms and the pregnancy outcomes of these women with PCOS. We also thought, and we still think, that metformin counteracts insulin resistance, especially the IGF-1 and also luteinizing hormone, because we still think that metformin acts on these TCA cells indirectly or directly and reduces hyperandrogenism. Way back in 1997, this was the concept. But we also know that insulin resistance acts on the ovary is questionable, but if it acts, it always acts on the TCA cells, and the cholesterol conversion to androgen is enhanced by basically the P450, the enzyme needed for progesterone to androgen is activated by insulin basically. But we also know insulin can act on the pituitary, again questionable, increases luteinizing hormone, and once again it has an action to improve or worsen the situation of androgen levels. Royal College of Obstetrics and Gynecology in 2004, way back in 2004, said that anovulatory women with PCOS who have not responded to clomiphene citrate and who have a BMI of more than 25 should be offered metformin combined with clomiphene citrate, because this increases ovulation and pregnancy rates. Women prescribed metformin should be informed of the side effects like gastrointestinal problem. I repeat, this is the publication in 2004. We have gone ahead 8 years later, and let's see what happened subsequently. We still think mechanism of action of metformin is all this what we know, decreases etc., all this hepatic glucose output, does not increase insulin level etc. But we also know it doesn't cause hypoglycemia. That's why we give. The Cochrane study in 2009 changed a little bit of our thinking, because Cochrane, as you all know, is a multiple publication which has been compared and studied, analyzed extensively, comparing metformin treatment with placebo or no treatment in women with PCOS who underwent IVF or ICSI. They were included. The review found no evidence that metformin treatment before or during assisted reproductive technology cycles improved live birth or clinical pregnancies. That gave us a kind of a jolt, or maybe made us a little bit more alert in understanding that metformin really did not prove, so efficacy of metformin was not really proved. The pooled odds ratio for live birth rate in 3 randomized controlled trials were 0.77. The confidence interval was, as you see in the slide. The clinical pregnancy rate in 5 randomized controlled trials were also published, proving it did not really affect. In 2002, a little bit before that, once again, in a randomized placebo-controlled double-blind crossover study of 3 months, they gave 1500 milligram, that's what we give, 500 3 times. They compared to placebo, followed by 3 months metformin placebo together with clomiphene citrate for another 3 cycles. Once again, there was no difference in the efficacy of clomiphene citrate between the 2 groups with ovulation. This showed that metformin is not always beneficial when given to clomiphene resistant infertile women in PCOS. Just to prove the same point, Lodge et al. In British Journal published in 2006 another randomized controlled trial where the objective basically was to establish whether metformin has a significant action in reducing visceral fat and improving other metabolic parameters in women. Jayakrishnan did show a slide on that particular point, but the study showed there was no significant differences in any of the measures of fat distribution between placebo and metformin. Of course, a couple of years back, Nawaz et al. Published this particular article. In a 3-year case control study conducted on 197 women with PCOS, in which cases comprised of women who continued metformin throughout pregnancy, while controls were women who stopped metformin after the first trimester. The study said there was significant reduction in early pregnancy loss. So I'm going on to the pregnancy effect because we know in infertility as such at the moment we are questionable treatment of metformin. When I read this article, it was 2 years back, I said that's good, at least somewhere it has a place. Maybe we can give metformin and prevent abortions. Again, of course, 2011, prospective cohort study wherein 360 non-diabetic PCOS were taken up. 200 women continued metformin throughout pregnancy. Control group 160 women discontinued. The study concluded in favor of the women who continued metformin use, who demonstrated statistical significant prevention or reduction in incidence of gestational diabetes. So one school of thought is if you have already given metformin, you can continue metformin in pregnancy and it reduces incidence of gestational diabetes. But everything has 2 sides of the coin. The literature is either this way or that way. A recent randomized controlled trial done in 100 women with gestational diabetes who did not attain euglycemia with diet were randomized. So I'm now talking about a woman who has already got gestational diabetes. They received therapy with insulin or oral metformin, concluded that metformin was better suited than insulin for prevention of fetal macrosomia, especially in lean or moderately overweight women developing GDM in late gestation. And insulin was preferred therapy for women with considerable obesity, high fasting blood glucose, and early need for pharmacological treatment. I did a little review of literature and published in the Journal of Human Reproductive Science in August 2012, but this review actually told us it is quite useful in pregnancy. The use of metformin throughout pregnancy with PCOS had shown reduction of early pregnancy loss, preterm labor, and even IUGR. Metformin has been shown to have encouraging effects on several metabolic PCOS such as insulin sensitivity and so on. The use of metformin therapy in patients have a beneficial effects on early pregnancy loss and development of gestational diabetes. I just had this publication of my own in this article, but a little bit later, once again, controversial articles have come up. In Human Reproduction, September 2012, Mary et al. has published saying, insufficient evidence to establish a difference between metformin and clomiphene citrate in terms of ovulation, pregnancy, live birth rate, miscarriage, and multiple pregnancy rates. The BMI of less than 32, so it doesn't really matter in a thinner woman. Probably all these metformin may help in a larger size woman rather than a thinner size woman. Caution should be exercised when prescribing metformin as the first line of therapy. I remember for years and years we've been giving and making the woman vomit all the time, having some gastric discomfort, yet we will tell her, you should swallow that metformin. So now, ladies and gentlemen, we know metformin is not needed in most of the women, except in probably a larger BMI one. Mary et al., same publication, proved in Human Reproduction 2012 by looking at this favoring or not favoring metformin. If you look at the right side of this picture here, you'll understand the midline. Anything crossing the midline on the right side would be significant, but you'll realize pregnancy rate per patient is on the upper chart. The lower chart says live birth rate. That dark area is never crossing to the right side. So most of the studies have not proved it to be beneficial. By looking at the miscarriage rate per pregnancy and multiple pregnancy on the right corner chart, most of them have not really favored, except some of the studies favoring metformin. What about in vitro fertilization? No benefit in metformin co-treatment before and during IVF in PCOS. Study on 134 women randomized, 16 for metformin group, 65 for placebo. No difference in live birth rate, clinical pregnancy rate, and ovarian hyperstimulation syndrome. Once again, Human Reproduction 2011. We found that Fertility Sterility 2011 December about OHSS. PCO people who are at high risk for ovarian hyperstimulation syndrome and who have been stimulated with gonadotropin for IVF cycle, metformin reduces the risk of OHSS by modulating the ovarian response to the stimulation. So we know that there are few areas where we can use metformin, and because the PCOS this is interesting, PCOS with reduced ovarian reserve, metformin worsened the response to gonadotropin, and its administration should be stopped before the treatment of controlled ovarian stimulation for IVF. But Professor Roy Humberg beautifully said, most of the PCO patients have a large number of antral follicles. They may not respond or they may respond. However, if you find that these reserve eggs are very less in these women as they age, probably they don't even need metformin. And I think that's what he said. As the woman ages, there are few lesser antral follicles. That means lesser of AMH. And that means they are more ovulating occurs spontaneously in an older woman. To summarize my presentation, use of metformin in infertility has been doubtful by recent reviews. So you don't have to give for everybody walking in. Co-treatment with ovulation induction is not showing improved results. No significant differences in any of the measures of fat distribution between the placebo and metformin group. Use in pregnancy seems once again controversial. However, a larger size BMI may benefit by metformin in producing results of reduction of gestational diabetes, reducing macrosomia, and insufficient evidence to establish a difference between metformin and clomiphene in terms of ovulation, pregnancy, live birth, miscarriage, and multiple pregnancy in less than 32 BMI. Thank you very much.